At the outset, I would like to thank each one of you for dedicating your precious time, and I would like to thank and express my deep gratitude to G Vijayakumar sir for giving this wonderful opportunity, and I thank chairpersons who are going to answer all the questions emanating from the audience. Thank you. So, the topic that has been tossed to me is HbA1c as a poor marker in hypoglycemia. So, before we delve into the topic proper, let us learn about what is hemoglobin, what is HbA1c, and what is a clinical implication of HbA1c, where it really falters in the assessment of hypoglycemia, and so on. So, what do you mean by hemoglobin? Hemoglobin is nothing but it is an iron containing metalloprotein which carries oxygen everywhere. It contains globin as a protein. This globin is made up of 2 alpha chains and 2 non-alpha chains. The 2 non-alpha chains may be beta chains, may be gamma chains, and may be delta chains. If alpha chains combine with beta chains, then it is called hemoglobin A, that is called adult hemoglobin. Please remember that adult hemoglobin makes up 97% of our total hemoglobin. If alpha chains combined with gamma, then it may be called as hemoglobin F. Then if it combines with delta, then it's called as hemoglobin A2. Collectively, it contributes only 2.5% of our total hemoglobin. Can you imagine how many hemoglobin molecules in single RBC? 4 or 40 or 400? Please remember that few million molecules of hemoglobin present in single RBC. So, generally in our body, monosaccharides have high affinity towards protein everywhere in our body. So, naturally, here the monosaccharides, namely glucose, galactose, fructose, these try to combine with globin moiety of the hemoglobin. So, it combines with all monosaccharides, combines with hemoglobin. When monosaccharides combine with hemoglobin, then it is converted into hemoglobin A1. It constitutes 6% of total hemoglobin. Only 6% of total hemoglobin molecules combine with monosaccharide, that is called hemoglobin A1. Rest of almost 94% of hemoglobin molecules that have not combined with any monosaccharide is called hemoglobin A0. Among this hemoglobin A1, that constitutes 6% which has combined with monosaccharide. Among this hemoglobin A1, if that monosaccharide is glucose, then it is called hemoglobin A1c. If other monosaccharide like fructose and galactose, if combined with hemoglobin A1, then it is called hemoglobin A1A, A1B. That's why when glucose combines with hemoglobin, then it is converted into hemoglobin A1c. That's why it draws much clinical attention. So, what is the history of HbA1c? Basically, HbA1c was commercially introduced in 1978. Then ADI endorsed HbA1c in 1988. Then DCCT study that was conducted in type 1 diabetes in 1993 highlighted the importance of HbA1c in such a way that it correlates with microvascular complication. Then ADA fixed HbA1c target in 1994. In 2010, what happened? The ADA broadened the HbA1c role in such a way that HbA1c can be utilized as one of the diagnostic marker for diabetes. Now it has been, so as I told you earlier, glucose combines with hemoglobin. Where it combines with globin. Which chain? Alpha chain or beta chain? It combines with beta chains where it is in the valine amino acid. This is a simple condensation. The most important is this condensation of glucose and hemoglobin occurs in the absence of any enzymatic reaction. That's why it is called non-enzymatic condensation of hemoglobin and glucose. In the absence of enzyme reaction, it occurs. So, now you have understood that HbA1c is nothing but condensation of glucose and the globin moiety of hemoglobin. So, whenever you have more and more hyperglycemia, there are more and more attachment of glucose over the beta chain of the hemoglobin, resulting in more and more HbA1c formation. So, now it is clearly understood that HbA1c simply reflects average sugar over 2 to 3 months of glucose duration, because hemoglobin lifespan is around 2 to 3 months. But the most important is whether it is a simple average or you have to something understand that what is weighted average. So HbA1c estimates the weighted average of blood sugar control. What do you mean by weighted average of blood sugar control? So this is the most important slide which should be focused by you. Please remember that it is not the each day of 90 days of your glucose level contributes to HbA1c formation equally. It is not the each day of 90 days of your glucose level contributes to HbA1c formation equally. It is the last 30 days of your glucose level that contributes 60 to 70% of HbA1c formation. The rest of 30% of the HbA1c will be produced by the first 60 days. So what I try to say that if someone maintains sugar level around 300 milligram of sugar, highlighting 10% of HbA1c in the first 2 months, then next one month he maintains only 145 milligram due to good adherence of medication and everything. So what is the end of at the end of 90 days, what would be the HbA1c level? For all practical purpose, as such the mathematical calculation, we will always think that the HbA1c level should be close to that 2 months of sugar level. That means somewhere around it should be close to around 300. It is not so. It always reflects last 1 month of your sugar level. The reason would be at any point of circulation, most of the RBCs, 60 to 70% of your RBCs are younger RBCs, which lifespan is only 30 to 40 days. This younger RBCs, 30 to 40 days of younger RBCs reflect your 30 to 40 days of sugar level. So now I told you, so whenever you have more glucose formation, more HbA1c, that means is the same principle applicable to hypoglycemia as well? No. So HbA1c basically will never reflect your fluctuation in the glucose level. It won't describe your day-to-day variability. Generally, the general assumption would be when you have high HbA1c, probably hypoglycemic episode would be low. When you have stringent HbA1c level, then hypoglycemic episodes will be high. At some point of time, this principle may be applicable, but there are 4 situations where HbA1c falters in the assessment of hypoglycemia. So, situation 1, 50 years old male, a known diabetic for past 5 years with recurrent hypoglycemic episode as evidenced by multiple CBG showing less than 70. Then finally underwent HbA1c testing. What is the expected HbA1c value? When somebody experiences so many hypoglycemic episodes, the expected HbA1c value would be somewhere around 5 to 5.5%. Am I right? What is the actual HbA1c value? 8.1%. Why this 8.1%? There may be 2 reasons. Even though despite development of hypoglycemic episode, still HbA1c is 8.1%, 2 reasons. Probably the multiple hypoglycemic episode might have led to frequent snacking, resulting in more hyperglycemic episode. The both hypo and hyperglycemic episode neutralize with each other, resulting in normal or mildly increased HbA1c. So here, if patient had not undergone any CBGs, then probably we would have missed out hypoglycemic episode by simply assessing the HbA1c alone. Then one more possibility, there may be true reduction in the HbA1c, probably maybe 5.5%, 6%. But there are few situations where the HbA1c level will be falsely elevated. For example, iron deficiency anemia and B12 deficiency, where what happened, there even though you have impaired RBC production, RBC lifespan is prolonged. Instead of RBC lives for 120 days, it lives for 160 days in the case of iron deficiency anemia. What happened? When when more and more glucose is exposed in 160 days of RBC, even though you maintain normal glucose level, then it will what happen? 160 days exposure may result in increased HbA1c. That's another possibility. So you have to rule out always falsely elevated HbA1c, something like iron deficiency anemia. The situation 2, 41 years old female with 4 years history of diabetes complains of recurrent giddiness, sweating, palpitation, compatible with symptoms of hypoglycemia. What is the expected HbA1c value? Considering the hypoglycemic symptom, expected HbA1c is somewhere around 5 to 5.5. But HbA1c is 4.7. It is much lower than what we have expected. So, what happened in this patient? Actually, this patient did many times CBGs during the time of hypoglycemic symptoms. But each and every time what he received is sugar level more than 250. Then I will explain this HbA1c. But the patient experienced hypoglycemic like symptoms whenever he did CBG only 250, but HbA1c shows 4.7%. The reason would be, the more possibility would be, when you have falsely lowered HbA1c, for example, if somebody is harboring hereditary hemoglobinopathy, G6PD, or hemoglobin variant, where hemoglobin lives only for 30 days or 40 days, that is called because of hemolysis. When duration of glucose, the duration of glucose exposure over 30 days of RBC, what happened, resulting in false lowering HbA1c. So please remember that in this patient, if patient didn't do CBGs, based upon the HbA1c, if would have acted, so what would happen? You will think that all the hypoglycemic symptom would be, all the hypoglycemic like symptom would be treated as hypoglycemic symptom, then that will force you to withdraw or stop the medication. So unless we do CBGs based upon the HbA1c, again you may be deceived. This another one more example. So 45 years old male patient was detected to have new onset of diabetes 3 months before. His fasting 220, postprandial 384, 13.1%. Then he didn't take any medication first 2 months. Last 1 month he took medication only to have recurrent hypoglycemic episode. So basically considering hypoglycemic episode, we expect HbA1c around 5 to 5.5. But what is the HbA1c value? 8.9%. The reason would be the first 2 months he has maintained good amount of sugar level. That may result in marginal elevation of HbA1c. Again, if you only rely on HbA1c in the assessment of hypoglycemia, again you may be disappointed. Then 60 years old male patient presented with several hypoglycemic episode. His fasting sugar is 220, postprandial 336. See, when you go by clinical signs, when you go by hypoglycemic symptom, what is the expected HbA1c? Somewhere around 5 to 5.5. But if you go by fasting and postprandial around 336, what is the expected HbA1c value? Around 11%. So what is the actual HbA1c value? 7%. So the 7% HbA1c value never reflected hypoglycemic episode, unfortunately never reflected hyperglycemic episode also, because fasting postprandial high but recurrent hypoglycemic episode. So this patient was subjected to CGM. What happened? So postprandial somewhere around 300, then suddenly pre-dinner he went into 40, 45. Again the post-dinner sugar level will be high. So the patient was on pre-mixed conventional insulin. Then he was on glebanclamide. So this patient developed hyper and hypoglycemic episode. So both hyper and hypoglycemic episode neutralized with each other, resulting in normal HbA1c. But unfortunately, HbA1c couldn't reflect neither this hyperglycemic episode and nor hypoglycemic episode. So is there any alternative marker? There are so many confusion. Yes, you can use fructosamine and 1,5 Ag, and you have CGM, of course, and capillary blood glucose, CBG. So glycated albumin, as I told you earlier, so our monosaccharide will have affinity towards any protein. The same principle is applicable here. Our albumin is bound with the same monosaccharide. So we are utilizing that principle. But only one thing is, albumin half-life is only 21 days. So it will assess the sugar level somewhere around 2 to 3 weeks. But only one thing is, when you find there are so many the hemoglobin false lowering, false increase, so at the time you can use. It's very, very useful in many conditions, but wherever albumin itself is excreted, in the case of nephrotic syndrome, it may not be useful. For example, albumin production is low. In the case of chronic liver disease, it may not be useful. These are the two conditions you have to be mindful. Then this 1,5 Ag they are telling, so it is inversely proportional to glucose level. When you have high 1,5 Ag, then you have reduced glucose level. When you have low 1,5 Ag, I think that you have increased glucose level. I think that it's not practically feasible. I have inquired. I think that no lab offered this service. And of course, the beautiful one is CGM. The biggest advantage of CGM is it can address your glycemic variability, which is considered as a major CV risk factor. So what is the take-home message? Low HbA1c can be associated with hypoglycemic episodes. Of course, But you have to exercise some kind of caution in the case of falsely elevated HbA1c, something like iron deficiency anemia, megaloblastic anemia, so on. You have to be very careful in falsely lower HbA1c, something like hemolytic anemias. And of course, HbA1c failed to reveal your glycemic variability. That can be only dealt by continuous glucose monitoring. HbA1c cannot detect your current hypoglycemic episode. That can be detected only by your CBGs. And overall, HbA1c is considered as a poor marker for hypoglycemia. So, I want to express my thanks once again for GVK sir for giving this wonderful opportunity. Thank you.
Thank you, sir, for this